invite Dr. Shrutakirty for post-fever optic nerve disorders.
Good morning to one and all. Today I will be talking on post-fever optic nerve disorders. Post-fever optic neuropathy is a rarely reported entity in literature which is associated with a wide variety of infectious agents, and it develops few days to weeks post-infection. The mechanism is either a direct invasion by the pathogen or post-infectious disease, which is mostly an autoimmune mediated demyelination or inflammation of the optic nerve. The etiological classification includes viral, bacterial, parasitic, fungal, and post-vaccination. Coming specifically to each of these, first is the dengue-associated optic neuropathy, which is mostly bilateral. The incidence of optic neuritis is 0 to 1.5%, and many of these patients present with anemospectrum disorder. The mechanism is either a direct viral infection or immune-mediated or vascular, as well as degenerative or inflammatory reaction. Next is the varicella zoster associated optic neuropathies. Varicella zoster can cause both varicella zoster and herpes zoster and may lead to acute retinal necrosis syndrome as well as progressive outer retinal necrosis. The optic nerve involvement has been reported in 17 to 18% of eyes with progressive outer retinal necrosis, and the eyes with progressive outer retinal necrosis associated optic neuropathy have a poor visual outcome despite being treated aggressively with the antivirals. Another thing is the SJDO associated optic neuropathy, which can occur simultaneously to the acute vesicular rash or frequently as a post-herpetic complication. And there is good recovery with systemic acyclovir and corticosteroid therapy. Next is HSB associated optic neuropathy, and the pathogenesis could be either due to intraneural vasculitis, compressive ischemia of the optic nerve, inflammation and necrosis due to direct HSB infection. The next is the chikungunya associated optic neuropathy, which could be either due to the direct viral mechanism or immune mediated reaction, and steroids accelerate the recovery if they are initiated earlier. Then is the HIV associated optic neuropathy, where there can be unilateral or bilateral clinical presentation, and the histopathological examination shows axonal degeneration along with demyelination, glial changes involving the vacuolated oligodendrocytes and mononuclear phagocytic cells, and mostly it is mediated by HIV-infected macrophages. Other viral fevers like influenza, cytomegalovirus, and COVID has also reported to be having viral fever associated optic neuropathies. Next, coming to the bacterial, the first is the typhoid associated optic neuropathy, where as per the paranoids and schemes theory of optic nerve changes, there can be cerebral congestion with serous effusion into the arachnoid cavity, lateral ventricles and subarachnoid space. It may occur as an vasomotor disturbance or an autoimmune reaction, and the management is with systemic antibiotics along with systemic steroids or oral carbonic anhydrase inhibitors. Next is tuberculosis associated optic neuropathy. As we all know, the diagnosis of ocular TB is mostly presumptive. The various mechanisms which have been reported are a direct mycobacterial infection or a contiguous spread from the choroid, hematogenous dissemination, or a type 4 hypersensitivity reaction. CNS tuberculosis can also be associated with optic nerve involvement, like in patients with TB meningitis, optochiasmatic arachnoiditis, and tuberculoma. Unilateral disc edema can also be seen secondary to tuberculous posterior scleritis, as we all know. Similarly, in Lyme's disease also, there can be optic neuropathy mostly in the early and disseminated stages, and it is mostly bilateral with a bimodal distribution of the age. In children, there is papilledema associated with meningoencephalitis, whereas adults have a variable presentation with papillitis, ischemic optic neuropathy, optic atrophy, as well as chiasmal syndrome. In malaria-associated optic neuropathy, there is a rare presentation of either a retrobulbar neuritis or papillitis, and the pathogenesis is tissue hypoxia because of the parasite which causes damage of the optic nerve fibers. Another entity is post-vaccination fever and optic neuropathy, where the event occurs hours to weeks after the vaccination, and the presumed pathogenesis is immune-mediated mechanism, which is mostly bilateral. The clinical spectrum is either a papillitis or a retrobulbar neuritis or neuroretinitis, and corticosteroids when given earlier has in the visual recovery. Coming to the pediatric versus adult cases, in the pediatric the presentation is mostly bilateral, whereas in the adults there is an unilateral presentation. The time elapsed is shorter in the pediatric group because of the fulminant immune response, whereas it is longer in the adults. The neurological manifestations are more common in the pediatric group as compared to the adults. The pediatric post-fever optic neuropathy is most commonly associated with acute disseminated encephalomyelitis, whereas adults have a more common association with multiple sclerosis and anemospectrum disorders. In the anatomical location, papillitis and papilledema are more common in the pediatric variety, whereas retrobulbar neuritis is most common in the adults. And there is a remarkable response to steroids in the pediatric group as compared to the adults. So I would like to highlight our experience at a multi-specialty hospital. We did a prospective interventional study of 1 year and included all the patients who attended the ophthalmology OPD and diagnosed as having optic nerve disorders with a history of fever within the last 1 month. There was a male preponderance in our study participants with a mean age of 23 plus minus 6.5 years. There were 7 children and 22 adults in our study participants. And the mean time which was elapsed between the fever and optic nerve involvement was found to be 2.53 plus minus 1.12 weeks. The most common etiology was dengue followed by Mycobacterium tuberculosis and typhoid. And in the fundus findings, papillitis and retrobulbar neuritis were more common. We did the OCT RNFL where RNFL edema and thickening was more common followed by RNFL thinning. In the neuroimaging findings on MRI, brain and orbit with contrast along with MRV with contrast, unilateral followed by bilateral optic nerve hyperintensities with thickening and post-contrast enhancement were more common, followed by transverse myelitis and radiological signs of the raised intracranial tension. Serum NMO was positive in 45% of the study participants and MOG was positive in 23%. There was a significant improvement in the best corrected visual acuity in logMAR units at 3 and 6 months of follow-up after a proper treatment of the patients. So, my tech clinic message would be, post-fever optic nerve disorders are a rare clinical entities with varied etiologies and presentation. The visual prognosis is affected by initial vision at presentation, the time interval which has elapsed between the vision loss and initiation of appropriate treatment, the severity of the neuroimaging findings, and of course, the seropositivity, that is the NMO and MOG status of the patient. There is the need for multidisciplinary approach, and as always, an early referral by a treating physician helps to achieve a good visual outcome. Thank you.
Take clinic message is an interesting thing. Okay, nice presentation. The one thing we would like to discuss is, like, in patients who present with optic neuropathy, I think we all differentiated majorly on the basis of whether the disc edema and optic neuritis, whether the vision is affected or not. If the vision is impaired, we take it on the side of optic neuritis, and if the vision is unaffected or less impaired, we go towards disc edema. So in children, like,
actually, it's not only the vision but also the color vision, contrast and the status of the pupil, whether there is a RAPD or not. So these all factors will guide us whether it goes in the line of the optic neuritis or whether it goes in the line of the papilledema.
Yes.
Along with vision, these factors are also important, and also we do the fills, OCT and other things.
yes, definitely, all these, but what I mean to ask here is that in pediatric patients, okay, like these patients I think would not be very much able to do rest of the tests. So there you have to mainly rely on your clinical findings.
Yeah, obviously.
Right? So like how do we go ahead with treatment in patients where we suspect it to be related to some infection? The optic neuropathy, the neuritis related to some infection. Do we directly start the steroids and or we wait for the investigations, or under the broad spectrum cover of some antibiotics, we start the steroids straight ahead, particularly in the pediatric?
No, initially we don't start the steroids. So first of all, we will do all the investigations, and after a pediatric consultation, when all the investigations are done and then the diagnosis is confirmed, then only we can start steroids. But usually that happens, yeah. So actually we have to work in a collaborative manner. So that in that case, then the patients will be benefited because they will be treated earlier. That's what I was
It
saying.
should be done like this, but is it the consensus we all do it by this?
As it was a
in
multi-specialty
cases of-
hospital, so there was a collaboration between all the departments. So we could treat the patients earlier because they were referred to us earlier. That's what happened in our.
In children, the prognosis is usually good.
Yes,
With the treatment, there's a very good visual outcome.
yes,
But in adults, there may be a compromise.
yeah.
The one thing I saw in your presentation, you said that the time elapsed between the presentation of optic nerve disorder in an adult is about 22 weeks. So a detailed history is required. We have to correlate that 22 weeks back he had a fever or some.
No, it's not 22 weeks. I told the time elapsed is a little lesser in the pediatric group as compared to the children.
You said 7 weeks in children and adults. I think 22.
It's not like that.
Let me see it again.
Yeah.
Yes, because the time gap between the attack of fever and the presentation, it's also very important.
So the time elapsed is longer, but it's not because we have the
In one of
criteria-
your slides, it was like this, in which there was a pie chart was there.
Okay, our
And
presentation.
let me see.
No,
And
we
this one.
told that the time elapsed. The mean time was 2.53 plus minus 1.12 weeks. There were 7 children and 22 adults in
And
our
22
study.
adults is a number.
Yeah,
Okay,
that
I
is
thought it's the
number.
weeks.
No,
Okay,
no.
okay,
Because the criteria of post-fever
Okay.
optic neuropathy is
Yes.
like it should be within 4 to 6 weeks after the
Yes.
onset of fever. Otherwise, we
Yes.
cannot
We
relate
cannot
it to
relate
that
it. That's the
neuropathy.
point. Okay, it's okay, fine. It's okay.
Thank you.